was asked to talk about CRPS and fibromyalgia in POTS. You may say, interesting combo. Why? Well, shouldn't be really too big of a surprise, to be honest with you, because chronic pain is a challenge, it's common, and we can talk about neuropathic pain, we can talk about musculoskeletal pain, myofascial pain, visceral pain, etc. At the end, probably there is still a common pathway, and certainly very much there is a big overlap between pain and a lot of other manifestations, including autonomic manifestation and whatnot. So the difficulty in studying pain is that most of these syndromes are heterogeneous. The population is not easy to study for a variety of reasons, because obviously if you are in pain, you are uncomfortable, you may have other comorbidities, and that impacts the whole system. And the thing is, again, pain impacts the patient as a whole. So it's not uncommon, and if any of you has even something simple as a headache or a toothache and you go to work, you know how long that day becomes. You get easily more tired, you're more irritable, etc., etc. Now, there are a lot of conditions associated with postural tachycardia syndrome that may predispose the patient to pain or even contribute to the overall pain in general. Probably the biggest one is Ehlers-Danlos loss, simply because, as well, I guess should be pretty obvious, but predispose the patient to subluxation, joint and soft tissue damage, and thus pain. And up to 20% of patients that have postural tachycardia syndrome also have other autoimmune syndrome, probably the most common being Sjogren and Hashimoto, but also celiac or lupus, all of which can have a significant pain component. Now, pain is always something that gets the attention of everyone whenever we get it. We are wired in a way that whenever we have pain, we react to it, appropriately so, as if we have to do something about it. It's really an alarm signal. And in some cases it is, in some cases, unfortunately, or fortunately, it is not. But still, the impact on the body function is substantial. There are definitely a lot of dimensions of pain that we needed to consider. And the first one is figuring out exactly where is it, what's going on. It's like, okay, I've got my finger smashed, I'm hurting right here, right now. That's pretty easy, pretty self-explanatory. Then there is a more global sensation that's impacted by this. So how do I react to this pain? How do I react to the disability that may imply? And then there is the suffering component. Now, everyone loves neuroanatomy, so just bear with me a second. Just to be simple, okay, figure the nervous system in columns. And so we have the lateral pathways. Those are really the more discriminative, the more phylogenetically newest structures. They're the one that tells me, okay, I smashed my finger, I'm hurting right here, right now, and this is exactly the point, and this is exactly what's going on. But then there are all the midline structures. And those are the ones that involve more the motivational and affective pathways. And is the one that are the more the spinothalamic, the paleo type system. So older from a phylogenetically standpoint. So we have that in common with the animals that are below us in the chains of evolution. And why are these important? Don't know if I have a mouse with it, anyway, pointer, but anyway. All those structures are shared by pain pathways, mood, and Dada autonomic system. Central autonomic pathways are exactly the same. Why? Because we react to pain. I mean, not surprisingly, if you have a sudden you smash your fingers, you have a palpitation, right? Exactly. So there is a big overlap, and the two interact with each other. Sometimes it's hard to know at that point what's the chicken and what's the egg. So one of the questions is the patient that has a hyperadrenergic syndrome, is the pain causing the hyperadrenergic syndrome, or is the hyperadrenergic syndrome that's changing the pain threshold? $1 million question, and obviously may change from one patient to the other. A little bit more of this. I won't bore you too much, but again, the point is the body reacts to it, and there are various ways that we react to pain, and depends upon the severity of the pain, the overall situation, your own cultural experience, background, religion, whatever. You can react to pain in two main ways: the flight and fight or the playing dead. And how does that how we respond will impact the overall body reaction to the pain. And thus, we may have a more or less effective way to cope with pain. But beyond that, specifically for the point of this conversation, is how the body responds to it in a more global fashion. And if you have basically a hyperadrenergic response, or vice versa, if you have a hypoadrenergic response, obviously the manifestations are going to be very different. We do modulate pain also, and we do so from the higher up circuits all the way down. And that's what we use to teach patients to not only cope with pain, but control the pain symptoms better. And basically, a lot of it, frankly, it's as ancient as the world, particularly if you look at Eastern medicine, yoga type techniques. Acupuncture, basically, this is the system that we utilize. No drugs, just our own internal pharmacological endorphin system and modulation to shut down the pain signal that's coming through. I'm just going to skip that one. So on the other hand, we also have the opposite. So if you have a maladaptive response, instead of controlling the pain properly, you may actually magnify the response, and that's obviously not something you generally want. But I can see, I think you all can see how things can change upon different situations. I think we all, when you watch, let's say, football season, these guys get hit to a way that you think, oh my God, if I got hit that way, I would not get out of bed for a month, right? And they get up, not even in 2 seconds, and make a phenomenal play the next one. Well, they use, in the most effective way, the descending pathways to inhibit pain and suppress it. They have it down to a T. They are very motivated. They have a lot of extra physiologic, if you want to call it that way, motivation to that. Not so for everyone. But then we have patients that reacts exactly the opposite way. You get a pain process ongoing, you catastrophize, and that's magnified the intensity of the pain itself, besides making you even more distressed. Anyway, enough of that. So also there is, whenever we have a pain signal, there is activation of a nociceptor peripherally. Some are the ones that are normally active, and some are generally silent and get activated only when there is a chronic pain situation. Then there can have ectopic firings, and that all these things creates a amplification of the pain signal, which then becomes problematic in a more chronic way. And there are various factors involved. There is a lot of interest about the sodium channel, particularly the NaV 1.7, which is the dorsal root ganglia, as well as 1.8, but particularly 1.7 is a key player. And indeed, there are drugs in development in the hope to shut down that system, to really block the pain signal from coming through and spreading upward. And again, I will draw your attention to the alpha-1 and alpha-2 adrenoreceptors, because those are key to complex regional pain syndrome, and also the role of inflammation. A lot of factors, a lot of the typical inflammatory soup, the way it used to be called, of all these factors that are released whenever there is an injury, but they're also released whenever there is a neurogenic process going on, such as neuropathic pain. So the process basically self-maintains. The body must have thought the pain is really critical for us to be safe, and indeed it is. If you are indifferent to pain or insensitive to pain, you're going to get in real trouble. But unfortunately, there is a price to pay. It's very difficult to shut down the system. There are you shut down the main highway, there are a lot of collateral routes that pain can find. And that's where the role of a global approach for managing pain comes in. How about at the central level? The same happened. There is obviously overdrive, particularly of the wide dynamic range neurons in the spinal thalamic area, and activation on the postsynaptic and NMDA receptor of the glutamate receptor and NK1. Upregulation of, again, another subtype of sodium channel, a lot of other factors, and plastic phenomena that occur, including new synaptic formation and limbic augmentation. So all these things result in what we call the chronic pain syndrome. So let's go to, gosh, I don't think you guys can read this. Well, maybe it's good, so you don't get too drowned into details. But let's move to the complex regional pain syndrome. What is it? It's a chronic pain syndrome, which in the past was called the reflex sympathetic dystrophy, then was recognized that the name was probably a little bit of a misnomer. So periodically, they like to lock us into a room and say, don't guys come out until you have a new set of guidelines and criteria. So a few years back, a group met to Budapest, and so now it's known as the Budapest Diagnostic Criteria for Complex Regional Pain Syndrome. So what's the key concept? Without too much detail, you can read the Budapest criteria anyway on your own. But basically, you need to have an inciting event that can be as trivial as a sprain or can be as big as a stroke. The patient must report a series of altered symptoms at the sensory level, such as particularly hyperesthesia and allodynia, vasomotor manifestation, pseudomotor manifestation, and there may be motor or even trophic changes. And the patient must display all this for a period of time that's out of proportion to what you would expect based on initial injury. And should be a diagnosis of exclusion. This is in a nutshell. Then there are a lot of other factors. But I think we all, if any of you has had a cast on for a long enough time, you know that when you take your cast off, you don't recognize your limb, you just say, ew, right? It's shriveled, the skin is flaky, etc., etc., there is no muscle, etc. Okay, then you recover. How long that is? Well, depends upon the initial injury. There isn't a one-size-fits-all. What if that continues? What if the pain continues? What if then the pain magnifies and there are a lot of other issues? Then we're dealing with complex regional pain syndrome. Now, this was a pretty nice article that Knudsen et al. Just published. Actually, I don't know if it's out. It's still probably just in the electronic version. Anyway, they really did a good review of all we know about complex regional pain syndrome, because over the years, the pendulum has swung. Yes, it's sympathetically maintained. No, it's not sympathetically maintained. Yes, it's caused by this. No, it's not caused by that. Yes, there is the central component. No, it's all about epidermal nerve fiber. So, bottom line is, all of those theories are true, and none is exclusionary of each other. And probably there is more than one factor going on at any given time for these patients. So what we know is that you obviously have an initial injury, and there is some local inflammation, right? You get smashed your fingers, you're going to be swollen, black and blue, et cetera, et cetera. Well, there is vasodilatation, there are changes at the local level. That creates a local phenomenon of neurogenic inflammation, which in turn, though, can maintain the process. And it's unclear how much of that is then primary or secondary, but results in endothelial dysfunction, And then very early, there is a lot of upregulation in the keratinocytes with a lot of inflammatory interleukin release. And that in itself can cause more endothelial dysfunction and possibly a dropout of the intraepidermal nerve fiber density, which then self-maintain in that sense. At a more systemic level, well, actually, still at the local level, you may have not necessarily an increased expression of alpha receptor, but the alpha adrenal receptors become supersensitized. There have been a lot of studies done. Actually, if you look at the venous blood from the affected limbs, the norepinephrine metabolites are lower, so lower level of actually norepinephrine in the affected limb, but the response is exaggerated, so there is a supersensitivity of those receptors. And also, though, at the same token, they've also seen that in a new regenerating fiber, the alpha receptor density is higher. That also can cause, besides the self-maintaining pain and the allodynia and the sensitivity to circulating catecholamine, creates, because of the general pain, you have a more global response. So, not surprisingly, you are in pain, so there is more catecholamine release, so you go into a hyperadrenergic state. And then the patient, and indeed there have been studies done on patients with complex regional pain syndrome, say, do they have an abnormal autonomic testing profile? They don't. You just see that they have an underlying hyperadrenergic state, which looks very much like patient with postural tachycardia syndrome. And then there is the problem of the central component. And this is a big, big thing. There is with the plasticity is altered in complex regional pain syndrome. You think that will be magnified at the central level. In reality, there is a shift. And the affected limb actually shrinks in the cortical mapping as opposed to the normal limb. And a lot of the new technique of therapy for complex regional pain syndrome indeed is focusing on that. And the mirror therapy, that's what's about. Basically, you try to fool the brain and you force a remap of the cortex. Needless to say, with all that comes a substantial amount of impact on the mood and anxiety, and then autonomic function in a more global manner. Last word about all this, there has been studies showing that there is quite a bit of autoimmune processes going on in these patients. And in fact, this patient may have autoantibodies to the alpha and the muscarinic receptors. And that's why a lot of these patients may have GI dysmotility, may have secretomotor syndrome, may have vasomotor manifestation globally that are really caused by these autoantibodies. So a very interesting syndrome. So this is just a little summary of what I just said. So how about pharmacological management for this patient? The standard is still starting with anti-inflammatory. We're talking that there is a lot of neurogenic inflammation. And then typical neuropathic pain management, anticonvulsant, antidepressants, topicals. And a very interesting set of medication that works for this patient are the biphosphonates. There is, there will be a whole talk on its own, but without going too much in depth on that, there is a direct anti-inflammatory effect on those drugs, as well as working on the bone remodeling. And the patient with complex regional pain syndrome, the affected limb usually has osteopenia. So that will be something that is being investigated more and more. Interventional approaches used to be said that if the patient does not respond to sympathetic block, they don't have complex regional pain syndrome. Nope, not true. Can simply be non-sympathetically maintained anymore, but they may still have it. Still, you may try sympathetic block. You can try epidural. Dorsal cord stimulation, of course, are probably now one of the most effective options for this patient. Intrathecal drug. and botulinum toxin for dystonia. But the most important thing is PTOT and behavioral therapy. Lots of focus on the functional recovery, working on the sensitization, relaxation, coping skill, reduction of the swelling and the contractures, mirror therapy, et cetera, all those things focusing on the cortical remodeling that I was saying before. Is there a relationship between complex regional pain syndrome and POTS? Actually, no. There is probably more, in fact, indirectly. Patients that have complex regional pain syndrome may manifest, if you test them, a little bit like POTS, simply because of all the catecholamines that are circulating, but not really much otherwise. And if they're coexistent, it's probably more an association, but not a cause of one to each other. As mentioned, there are adrenal receptors, MM2 receptor identified that could be causing that, and that could also explain why this patient may have urinary and gastrointestinal symptoms. So I pretty much said that. That's why I already said. So next talk. Let's second part is the fibromyalgia. The criteria for fibromyalgia have changed so that now, except for the fact that you must have symptoms for at least a few months, if you have a bad day or if you had a bad night, if you're on call, wherever, you will fulfill all those criteria. So basically what I'm saying is it's very easy to fulfill those criteria of diffuse aches and pains throughout the body, and then you must have other symptoms, fatigue, irritability, irritable bowel. So the classic package of dysfunctional syndrome. Excuse me. And the patient don't need to have everything, but I remember one time I was seeing a lady for a completely unrelated reason, and she came with her daughter, was in her 20s, and she said, can I ask you something? I know you're here just to see my mom, but while I was in the lobby, I did this self-test for fibromyalgia, and I think I have it. I said yes to 75 out of 110 points. I said, good for you. Wow, you self-diagnosed. Okay, so, patients are pretty savvy these days. The point is, God, do I need to target every single one of those 74 symptoms? No, they come in a package. So don't freak out. Don't be drowning trying to address all of them. You won't have the chance. I mean, if you have 1 hour to see a patient, there is no way you can address 74 symptoms specifically. So just go as a topic in a global manner. And with that usually comes also chronic fatigue, which is, again, I explained persistent fatigue for 6 months or more due not to ongoing exertion, not relieved by rest, et cetera, et cetera. And usually patients have a lot of other symptoms, such as malaise, impaired memory and concentration, the famous brain fog, sounds familiar, unrefreshing sleep, muscle pain, headaches, sore throat, tender cervical axillary lymph nodes, et cetera, et cetera, et cetera. And this is what usually we kind of try to approach these things in a more global manner and say, okay, how do we put all these together? Why do they come together? You remember the famous slides of the Neuroanatomy that I know you all love and memorized to the T? It's the same pathways. Pain, motivation, mood, they're all in the same pathways. And why do you say the cognitive changes? Well, they become very inefficient. If you're tired, if you're paying attention, if your body is draining you because you are in pain, you simply won't have enough energy, enough fuel left to feed your brain. It's like if you have a tank in a car that has a leak. You're not going to be able to go 300 miles or whatever your car capacity is. You're going to go 100 miles. So it shouldn't come as a surprise, but just for the patient to understand that goes a very long way. Why does this happen? We don't know exactly why some people develop these symptoms and others don't. Same for complex regional pain syndrome. how many of us have a little strain every single day? There are a million of people that get minor injuries every day, more or less minor, and only a fraction develop complex regional pain syndrome. Maybe there is basically a more brittle electrical system with fuses that probably were not strong enough. Problem is we cannot change the fuse in the body. We are who we are. We have to deal with ourselves. So there is, again, a lot of factors that play into all this. Could be, again, genetic predisposition, psychological factor, physical factor, et cetera, et cetera, et cetera. The result is the same. Patient doesn't sleep well, the mood goes down the toilet, they are tired, they are in pain, and keep going in circle. Why all this? Well, it also becomes that they are not coping well. So again, we all have stressor every single day. And we are supposed to reset after each event, proportionate. Not every event is the same, right? If I get upset because I missed my flight, okay, then I settle down. If I get upset with my husband, could be more or less than missing the flight, depending upon your situation. I may be a lot more upset if I may lose my dog. Now, if then, your best friends from college passed away tragically, now that's a big stressor, right? So that's why we have, the normal grieving process when we have a major loss. But still, things eventually should go down. Some patients just don't seem to reset. And then they keep going up beyond what's the breaking point. And at that point, you have to really go climb up the Mount Everest and pull them down with a lead balloon. And that's basically what you try to do with this patient. So you work on all these various components, physical, emotional, cognitive, behavioral, et cetera, and you try to bring them back to being functional. And this is basically the concept of central sensitization. There was a whole special number of journal behavioral applied psychotherapy, whatever, all dedicated to central sensitization. See it the same way as you see memory. The more you practice, the more you develop specific circuits, which you may not necessarily want in reality, but the body doesn't know. If I keep practicing because I want to start playing the piano well, I create a special circuit. If I keep sending a wrong signal with a maladaptive behavior or a bad stimuli like pain, well, I may not want it, but the brain perceives, hey, you keep sending me the same signal, let's create a privileged pathway. Boom, and there you have it. And basically, it's just amplifying the gain on the amplifier of your stereo. The problem is you don't have like a button or a handle in the body that you can just tune down. So you have to go with other ways to manage it. And what are good ways that we generally recommend? Relaxation, exercise, exercise, exercise. We hear that all the time. Good sleep hygiene, decrease in perfectionism. Things don't have to be perfect. It's better good now than perfect never. Have a positive outlook. Again, be Tigger, don't be Eeyore. Have a sense of humor. Good diet. Healthy boundaries. Okay, it's okay to say, no, I'm not going to go to every single football, baseball, dance class that my kids have. Just say, okay, Mama today is going to one thing, not 16. And meaningful free time activities. What's meaningful for me can be very different, obviously, what's meaningful for you, but everyone has to figure it out. And those are the negative component. And I'm just going to leave you with this one, simply to say that there is really a big, big bad vicious cycle when you have this chronic pain, chronic fatigue syndromes, because there is obviously a component of behavior and emotion and family response that feed each other. And the longer you go, the more dysfunctional it gets, and the harder it is to go backward. I'm just going to leave it there. How about that?